Good morning. I'm Doug Wood, the Chair of Surgery at the University of Washington, and today we're going to be talking about what criteria we should be using for including patients for screening for lung cancer. I have three world experts here with me today. I'm going to have each of them introduce themselves and then we'll get started. Dr. Farja.
I'm Farhud Farja. I'm a thoracic surgeon at the University of Washington in Seattle.
I'm Tommy D'Amico. I'm at Duke University Medical Center.
And I'm Frank Detterbeck, Chief of Thoracic Surgery at Yale University.
So this is an exciting time. We're 3 years into coverage policy that actually now covers patients to be have lung cancer screening with low-dose CT. And the American College of Chest Physicians has recently updated their guidelines, and we'll have a little bit of a debate format about whether those guidelines are what we should use for determining which patients should be eligible for screening. I just want to acknowledge that all of the groups caring for patients that are at risk for lung cancer are well-intended and are trying to do their best to identify patients that have a legitimate risk and should be screened, as well as trying to avoid the unintended harms of screening, particularly the harms of false positives and the downstream testing of false positives in screening. So it's difficult to find the right balance to that, but it makes an area for discussion and some differences of opinion between which patients should be eligible for screening. So I'm going to turn to Dr. Detterbeck. Dr. Detterbeck, you've been very involved in the American College of Chest Physicians, ACCP guidelines for lung cancer screening. Originally published in 2013, recently updated just now in 2018. Can you kind of highlight the main principle, at least the patients included for recommendations for screening in 2013, and how that's been updated in the 2018 guidelines?
Okay, well, it's people that have a history of smoking, age 55, formerly to 74, now in the new guidelines to age 77, with a 30-pack year or more history of smoking and that have quit smoking less than 15 years ago. So, you know, that's fairly similar to the NLST study that forms a big part of the basis for screening. A difference, slight difference in the 2018 guideline versus the 2013 guideline is that we did talk about some additional factors. So we addressed the risk models that have been explored and said that we did not recommend that risk models be used as a routine for inclusion in screening. We can talk about that a little bit more. We did recognize that there is clinical judgment, and I'm very much a proponent that you can have guidelines. Guidelines give you some direction, but guidelines are not meant to take the place of clinical judgment. Clinical judgment is still an important factor, and I think that there are some patients that may have enough of a risk of lung cancer but do not have as high of a risk of dying of comorbid illnesses and may be good candidates for screening. And so there's some wiggle room in the new guidelines that clinical judgment may be used to select some patients. However, it's hard to put that into a guideline as a routine coverage, routine recommendation thing. It ends up being clinical judgment. Right. And then I would just add one little thing. I think that, you know, we recognize in the guidelines more explicitly the fact that there are very indolent lung cancers that are found, and that you find a lot of other non-lung issues on screening that you have to sort out. And that is a little bit of a byproduct of screening that, you know, I think we need to recognize a little bit more, that it kind of factors into the real life implementation.
Thank you. And I'll turn to Dr. D'Amico, because Dr. D'Amico, you've been involved in the guidelines development and leadership of the National Comprehensive Cancer Network, or NCCN, for a long time. And probably they're the other big organization in terms of lung cancer screening guidelines. How do those guidelines differ from those that have been recommended by the ACCP, and why?
Well, the the NCCN has a tremendous experience in guidelines, and one of the things we've learned that while clinical judgment certainly should guide the care of the patient, it does not always guide coverage decisions. And so we've always tried to put in the guidelines, in algorithms, language that could be interpreted by third parties as acceptable clinical care. Now, you can't predict every single ramification that might lead to a decision to perform screening, but the NCCN guidelines have always been algorithm-based, whereas the CHEST guidelines, which are great, are more evidence-based by specific issues, 15 issues in the current guidelines, as well as direct response to numerous questions. It's an excellent document. It spends a little more time worrying about avoiding false positives and unnecessary biopsies and unnecessary procedures, which we should all be aware of. But I think they're both complementary in terms of how they guide physicians to take better care of their patients.
So I might throw a curveball at you here, but I think that a strength that is promoted of ACCP guidelines is being very strictly evidence-based. And I think often NCCN talks about adding to evidence basis with also consensus-based components. Can you tell us what that means and why adding to what we know in evidence basis is important in terms of helping clinicians care for patients?
Well, although I believe in the NLST guidelines, if we don't create a consensus or another decision-making process, we'll never improve the screening process. Nobody believes that the NLST guessed it right, and the group of people 55 to 74 are the only people that are high risk. And I think the intention was always to create a registry and try to define a better high-risk population. For example, someone who's 55 and smoked 31 pack-year history of smoking has a much lower risk than a 49-year-old that has a 50 pack-year history of smoking. But we're only screening the former patient. So allowing consensus guidelines, and there are 32 members of the panel, as the chair well knows, including every specialty, including a patient advocate, that allows us to think beyond where we are. What we don't have is the ability to collect that data and see if we're correct. But if we create other risk groups, then we can then retrospectively analyze them and say, did we predict correctly? And a recent paper by the Leahy Clinic has done that. It has looked at separate risk groups than the standard NLST criteria and demonstrated that they could accurately predict similar risks.
And can you summarize just briefly what the fundamental kind of additional group is that the NCCN has said could be considered for screening? Sure,
and so the group 1 screening criteria is strictly NLST, 55 to 74, 30-pack years history of smoking, and quit within 15 years, as the CHEST guidelines are. But they've added a group 2, which is anyone older than 50 that you would interact on. So a lower age group and no upper age group, with only 20-pack year history of smoking, no quit date, and at least one other risk factor, either a personal history of cancer, a family history of cancer, or other factors that clinicians could use to guide their judgment to say, yes, this group is high enough risk to justify a 1.5 millisievert screening.
So that's where a patient with asbestos exposure, for example, might fit in.
Correct. Other clinical factors, radon exposure, that the NLST could not have possibly captured.
Right. Well, I'll turn back to Dr. Detterbeck then and say, yeah, that sounds reasonable. What would be the reason, what would be the rationale for not extending screening recommendations to patients with other risk factors? What's the concern? What's the downside of doing that?
Well, I think there were a couple of concerns. So one is that many of these other factors, we haven't really quantified very well exactly how much that adds to the risk. And for at least some of the factors, it probably doesn't add a lot. So I think that there's some uncertainty there. I think another aspect of it is that as risk for lung cancer goes up, so does the risk of, competing causes of death, so does the risk of problems with treatment for lung cancer, and those aren't really part of the models that we have right now. The models we have right now really are geared towards identifying what is your risk of development of a lung cancer, which is clearly a key factor, but it doesn't exactly translate to this is the benefit of screening in that population. So those were kind of major considerations that we had in saying, we're not sure we're really at a point where we can, on an evidence basis, say we really know exactly how these risk models work, how these other factors work, and how they translate to a benefit in screening, and therefore can't really say as a routine that this is what you should do.
So Dr. Farja, we've got a couple of different guidelines that make some different recommendations for which patients ought to be considered for screening. And now we have all sorts of online risk calculators where we can plug in some numbers. Tell us about those. What risk calculators we have, and is there an advantage of ignoring the guidelines and looking at risk calculators for helping primary care doctors know which patients should be recommended for screening?
So there are two types of risk calculators. One that predict the probability of getting lung cancer within a certain time frame, and another type of risk calculator that predicts the probability of dying from lung cancer within a certain time period. There are at least 5 risk calculators out there. One of the most commonly cited ones was published by Tom Amagi in the New England Journal of Medicine in 2013. And what that does is it takes many of the elements that go into both ACCP and NCCN guidelines, and it's an empirical way of identifying a high-risk group. It's conceptually exactly the same. It's just that the current ACCP and NCCN guidelines use what I might call coarse predictors, whereas the risk calculators would use fine predictors, or other way to say it is you use more information, which should lead to better prediction. Better prediction should lead to better risk stratification, and clinically that means better patient selection. So there is actually some evidence of this. There's an article by Kowalczyk in New England Journal of Medicine in 2013. There's a secondary analysis of the NLST, and you can just think of it as a post hoc subgroup analysis where they looked for the benefit of screening in different subgroups defined by predicted risk of lung cancer death in 5 years. And what's interesting is the benefit that we all know of lung cancer screening was shown in all groups other than the lowest quintile group. So that's an example of how risk calculators can actually shrink or restrict access to screening in those people where apparently there's no benefit. The one limitation of that study, it doesn't show the other side of the coin, which is it could greatly expand access to lung cancer screening. And when you think about it, it's hard to imagine a reason why, if you have an asymptomatic person who's otherwise eligible for lung cancer therapy that has an equal or higher risk of dying for lung cancer, that they would not benefit from screening. So in a nutshell, it's better individual selection for screening.
Well, I would.
So let me ask a question though about, where does that research go? What other research is there in lung cancer screening?
Yeah, so with regards to using risk calculators, one of the biggest challenges in that area is that we're not routinely collecting those risk factors. So it's hard to use these risk calculators. It's hard to automize their use, meaning you have the information in an electronic health record and it automatically populates a risk calculator. So that's one of the challenges. A new area of research, relatively new area, is implementation science, and that can greatly help us. The NCI actually has a team that's educating researchers about the methods used. And implementation science is basically taking evidence-based interventions and translating them into clinical practice. And that kind of work addresses some of these issues of how do we create a health system where we capture these risk factors and we don't have to plug them in, but the computers will basically give us the probability and the risk strata and guide us in the direction of doing screening. Or not.
So I'm going to give each of you a great opportunity. So this is a chance to be king for a day, or maybe more importantly, senior Medicare administrator for a day. So Dr. Detterbeck, I'll give you the first shot. You're running Medicare. What would be the way that you would like to see lung cancer screening implemented, or at least which patients should be included in Medicare coverage policy? You're the boss.
Well, if I was in charge of Medicare, I would focus, I think, a lot more on the organization of a program. I think if you have a program, you are thinking carefully, you are collecting data, you are looking at your outcomes, I think you can do a good job. And we don't have good metrics for that. We don't have a good way of assessing that and evaluating that. But I'm very comfortable from having seen many people try to implement screening that when people do it thoughtfully and carefully, I think that they basically do a good job. So I would try to create more metrics around that and give the programs a little bit more leeway to do that. Now, if I was in charge of everything, more than Medicare, you know, one of the things that I would do is I would create a pot of funding for a number of pilot, maybe phase 2 sort of implementation studies to say if we are going to extend, if we are going to use risk calculators, if we're going to use different thresholds for what we call a nodule that requires further investigation, you know, how does that actually translate and how does that work? I would create a number of projects that look at that so that we can get the information that we need. So,
and I'll ask you, Dr. D'Amico, briefly, you know, what, king for a day, running Medicare,
sure.
What would you do?
Two things. Number one, find a better way to enforce the current guidelines. Even if we don't use Group 2 guidelines from the NCCN, we still operate on more patients that should have been screened, but their tumors were found otherwise, than patients that were successfully screened. So the percentage of people that are being screened that should be screened is too low. We would never tolerate that for mammography or colonoscopy. And secondly, to fund or at least encourage the implementation of secondary screening modalities such as metabolomics, radiomics, proteomics, volatile organic compounds to lower the false positive rate of screening so that we can focus on future screening and interventional procedures on those that really have lung cancer.
Right. Dr. Farja, you get to have the last word. Yeah. You're running Medicare. What are you going to do for lung cancer screening?
So I would do everything that has been said, but I would make the guidelines state use a risk calculator.
Yeah.
Okay, well said.
Use it and pay attention to it.
Yes.
Yeah.
So I want to thank Dr. Detterbeck, Dr. D'Amico, and Dr. Farja for their really important comments about the implementation of lung cancer screening and how we pick the right patients for lung cancer screening today. It's a delicate balance between identifying the patients that have enough risk that ought to be screened so that we can find early stage lung cancer and offer a potential for cure, and trying to minimize the negatives of screening, which is finding false positives in patients that don't need downstream testing or are going to be harmed from downstream testing. So I guess I would sign any of you up for running Medicare, given your knowledge at least about lung cancer screening, and hope that as we get better at lung cancer screening, we can have more and more patients that we're identifying with early stage disease instead of late stage disease, giving us a chance to create more lung cancer survivors. Thank you.